EU 代表講演といたしまして、2019年の欧州臨床腫瘍学会会長で、肉腫などの希少がんを含む世界のがん医療の権威であるフランスレオンベラールセンター教授ジャン・イブ・ブレイ様にご講演いただきます。テーマは、がん撲滅に向けたがん治療最前線2022です。ジャン・イブ・ブレイ様の講演は、事前に収録した VTR 映像でご覧いただきます。それではお願いいたします。
Good morning, good afternoon. My name is Jean-Yves Blay, and I would like first to thank the organizers for inviting me to this World Cancer Eradication Summit to present this question of forefront of cancer treatment. I'm a medical oncologist working in the Comprehensive Cancer Center of Lyon, France, in the Centre Léon Bérard. I'm also the Director General of this hospital and the President of the French Federation of Comprehensive Cancer Center, Unicancel. These are my disclosures, both as a researcher and as a director of the hospital. I would like to cover 3 topics today which are connected, which all aim to improve and transform the way we treat cancer patients, illustrating these examples by some results which have been transforming already for the care of cancer patients, starting with networks of reference centers, and more specifically, networks of reference centers for rare cancers. Why rare cancers? Because we all know that rare cancers are associated with a worse outcome. They represent overall, altogether, 22% of all cancers, yet 30% of the deaths, because of less good diagnosis, inappropriate treatment strategies, less research. Because of this, several countries, including some decades ago, Nordic countries, United Kingdom, and several others, have organized networking around reference centers to manage cancers which are known as rare, definition inferior to 6 per 100,000 per year. And this was also the case in the country where I work, France, where since 12 years, network of reference centers was installed on the basis of the work of the Institute ANCA, French National Cancer Institute, which prompted us to organize a network of reference centers in sarcoma, which I'm going to give you as an example. Our objective was to promote guidelines, to improve patient pathway, to measure the impact, and to develop research. And this map shows you the networks and how patients are coming to the different centers. This was an exercise which we built on a network database. Sarcoma BCB NetSarc Plus is a database which is online, which can be accessible, where we include all patients with rare cancers named sarcoma, which have been centrally reviewed by pathologists. And this database now includes over 110,000 patients with connective tissue tumors reviewed in this network since 12 years. The important observation we made first was that patients treated in reference center, as you can see on the survival curve of the right panel, have an improved patient outcome, survival, as compared to patients operated outside the reference center. Green curve versus blue curve. This database also enabled us to collect an exhaustive series of patients with sarcoma, defining better the incidence of these rare tumors. But more importantly, when we looked at a global level, with this exhaustive data set that we have in this nation, looking at patient survival in the latest years, 2016 to 2020, we observed that the survival of patients with rare cancer overall improved in this country. We know that by comparing to the previous period in blue, 2013, 2015, and to the previous period in which was not exhaustive, 2010, 2012. So this organization has enabled not only to have an accurate diagnosis, not only to have an improved patient treatment within the reference centers and outside, but also overall to impact significantly to reduce the risk of patient death, here looked at 12 months, with a reduction which is of a magnitude close to 20%, as you can see. Nothing is improving better patient survival, so this should be organized for the future. And this is also the case, surprisingly, for patients with metastatic cancers, metastatic sarcoma upfront. The conclusion for that is that network of reference centers for rare cancers is able to significantly improve patient outcome when properly organized. Switching to a different topic, but this is really connected because molecular screening is part of what we try to do to better diagnose patients with rare cancer. But molecular screening has also an impact on all cancers. And one of the questions is, should we make that as a routine for all patients? And what should be the size of the molecular screening we proposed? We explored this question in a trial which was called Profiler 2, exploring two panels, two sides of panel. The first control panel, which was locally developed in one of our centers, and compared to a more exhaustive panel, including over 400 genes, and trying to see whether a larger panel would result in an improvement in the proportion of patients in whom a treatment could be proposed and could be guided for the next line of treatment with this tool. So this was a randomized study where both tests were conducted, and one test was used first, and if not conclusive, the second test was being used. And what we observed was that this was truly the case. The larger panel was associated with a higher number of recommendations for targeted treatment and immunotherapy. And the larger panel was also associated with an increasing proportion of patients in whom a targeted therapy could be recommended. And the p-value was significant, as we can see here. A larger panel associated with better management of patients for the subsequent line. And this is, of course, very informative at a time where a large number of countries are organizing strategies to screen patients with broader tools. Whole exome sequencing, whole genome sequencing are being investigated for the analysis of patient tumors in a large number of countries. This is the case in the country where I work. The French FNG 2025 plan is exploring the role of WGS. Will this improve further the outcome of patients treated in this setting is still an open question and is still being investigated. But no matter what, it's quite clear that molecular screening is now part of the routine treatment of a large number of cancer patients, and that probably broader is the better. Time will tell. The last topic I wanted to cover, which will be slightly longer, is a question of immunotherapy of cancers in 2022. We really live a revolution. And this revolution is based on the understanding that almost all cancers, at least a fraction of all cancers, do benefit from immunotherapy approaches. Why is that? We now understand that there is a large number of biomarkers which are associated with response to treatment, with response to immunotherapy, and including lymphocyte infiltrates, including tumor mutational burden, including microsatellite instability I as a biomarker for patients with a wide variety of different cancers. And this was the first agnostic marker, actually, which was identified some 5 years ago. And on the basis of that observation, this randomized study of pembrolizumab in microsatellite instability I advanced colorectal cancer comparing pembrolizumab versus chemotherapy was extremely informative, showing an improvement in progression-free survival with immunotherapy for patients with MSI tumor. And you can see here that the difference is particularly high when you look at patients beyond 12 months. And this probably is going to change how we treat these patients with specific immunological characteristics, not only colorectal cancer, but also a broader number of cancers was shown on this study, which was more conducted as a basket study, with which was including patients with non-colorectal high microsatellite instability and mismatch repair deficient cancers, with a wide variety of different histological subtypes. You can see here a large number of patients, over 230, and we can see here that the impact of immunotherapy with pembrolizumab was also very significant, showing tumor shrinkage, complete responses, partial responses in a large proportion of patients. So again, an agnostic approach, but completely agnostic in a sense, because we see that not all cancers do respond to this approach, but at least an evidence that this biomarker, this agnostic approach, is relevant for a larger number of tumor types than colorectal cancers. And that's probably going to be a very important information for the future. In particular, when we consider still focusing on MMR proficient and MMR deficient early stage colorectal cancer, when we now look at the outcome of patients when we expose these patients with localized tumor to neoadjuvant treatment. And there was the first very important study describing neoadjuvant immunotherapy leading to pathological responses in both MMR deficient, but also MMR proficient early stage colorectal cancer, as you can see here. And this observation is very intriguing and was actually completed by the observation recently published in the New England Journal of Medicine, showing that in locally advanced rectal cancer, a majority of patients treated in a neoadjuvant setting with a PD-1 antibody achieved tumor shrinkage, massive tumor shrinkage, complete pathological response for the majority of these patients. And of course, this is an observation which has the potential to transform the way we treat patients. This was confirmed in the recent niche study reported at ESMO 2022, where actually neoadjuvant treatment with nivolumab, ipilimumab, then nivolumab was given before surgery, with a primary endpoint which was not to delay surgery, and the secondary endpoint, co-primary endpoint, which was disease-free survival at 3 years over 90%, as you can see here. Description of patients is provided here with over 100 patients with a median age of 50, and as you can see, relatively large and high-risk tumors. What is absolutely amazing is the rate of complete pathological response and major pathological response. We can see here numbers which are truly mind-blowing, changing the perspective by which we treat patients with MSI localized colorectal cancer. Surgery was not delayed. The follow-up is still short, but there were no relapses. So this may well be in the future a new standard, and how this will change the treatment of patients with colorectal cancer and localized colorectal cancer is something to be studied further. This is transforming. This is really a revolution. Also is a revolution the concept that early treatment, neoadjuvant treatment, may have advantages over adjuvant treatment. Why is that? We know that from the OPACIN neo study in melanoma, observing that a patient treated with neoadjuvant treatment who had responses to this neoadjuvant treatment seemed to have a much better outcome than patients treated with the same approach, but without responses. And when we compare, this is not a formally randomized study of a size enough to demonstrate this point, but observing that neoadjuvant may be superior to adjuvant approach in this perspective, probably related to an increase in the proportion of immune cells able to recognize and destroy the cancer cell. And that's probably, again, a forthcoming revolution on how to treat patients in the future, privileging a neoadjuvant treatment as compared to adjuvant treatment. Again, research is needed. As more research is needed for the use for solid tumors of cell therapy. And I think that the observation that this approach, in this case, recognizing in an HLA-A2 context, tumor cells expressing antigens such as MAGE-A4, in this example, was again a big change in how we understand the treatment of patients with advanced disease. Sarcoma, synovial sarcoma in particular, are associated with a poor outcome when all treatment options have been exhausted. And in this case, these patients were treated with autologous cells modified to express a receptor, a T-cell receptor recognizing MAGE-A4 in HLA-A2 context, showing complete responses, partial responses, which are long-lasting for a large number of patients in all the patients that were treated in the center where I work, we still have prolonged progression-free survival without any relapse. And that's, again, a practice changing, possibly, and actually concept changing strategy to treat patients with advanced cancer. This is probably not going to be the only approach for immunotherapy. It was amazing to observe in a retrospective analysis of the electronic patient records in our center. It was amazing to observe that patients treated for their first cancer with immunotherapy were actually at lower risk to develop a second cancer. In this series, including over 40,000 patients, this was highly significant. A subsequent series, an independent series, is now under review, showing similar improvement, reduction in the risk of developing a second cancer after being treated for a first cancer. And this is, of course, opening a new area of research of preventive therapeutics for patients at high risk to develop a cancer. So I will conclude here by saying that we are now at the forefront of cancer research in several topics. Networks of reference centers improve survival. Precision medicine improve patient access to treatment in advanced phase. Immunotherapy, we have many new frontiers. And we have much more in prevention and in precision medicine. So with that, I would like to thank you for this invitation. And I will be happy to address questions you may have, of course, by email. Or with other means that you may want. Thank you very much.
ジャン・イブ・ブレイ様のご講演でした。ありがとうございます。